Everyone for joining us this evening. We have an important talk today in regards to AMR and during the COVID-19 pandemic, as well as the importance of infection prevention and control. So presenting today is Dr. Gina Maki from the Henry Ford Health System Department of Infectious Disease. And we also have Dr. Marcus Zervos, who is the head of the Infectious Disease Department at Henry Ford. Both Gina, Mark, both Dr. Maki and Dr. Zervos have worked in Nepal over the last several years, as well as I've worked there, focused on antimicrobial resistance. So we had a request to talk about AMR in relation to COVID. And so I will turn it over to Gina.
Okay, good evening, everyone. Thank you for joining us and for coming to our talk. So I'm going to get started with sharing my screen and going through the presentation. And then after that, we'll have time for questions, which you can always add in the chat box or wait till the end and we can talk about them as well. So let me just share my screen. Okay, and you can see that okay? Okay, so this talk will be about, thank you, about COVID-19 and the effects on antimicrobial use, as well as the importance of infection prevention and control. So we'll review a background of the COVID-19 and disease, a brief review of treatment options, and then we'll talk about resistance and infection prevention and control in relation to COVID. So as we all know, the COVID-19 disease is caused by the severe acute respiratory syndrome coronavirus 2, named SARS-CoV-2. So COVID-19 being the disease and SARS-CoV-2 being the virus. The timeline of COVID-19 that we're all quite aware of is the first cases were reported in Wuhan, China back in December of 2019, almost a year ago now. And then in January 23rd of 2020, Wuhan declared a state of emergency, and then the pandemic was declared by WHO on March 11th of 2020. Since then, COVID has come quite a long ways. So this is a snapshot from earlier this week. And as you can see worldwide, there's been 66 million confirmed cases of COVID and 1.5 million deaths around the world reported to WHO, and this number just continues to increase. From earlier this week, we can look at how Nepal is faring as well. So though you can see the United States and India are the top two, unfortunately, cases and deaths worldwide, Nepal still has quite a few. So Nepal has had, again, this is from earlier this week, but at least 240,000 cases and over 1,500 deaths now cumulative over the course of the pandemic. So we'll talk about the microbiology of COVID. So the SARS-CoV-2 virus is part of the coronavirus family. It is an enveloped positive single-stranded RNA virus surrounded by spike glycoproteins. And those spike glycoproteins are the target for many treatment options and vaccines. The COVID virus enters the cell through membrane fusion. How is it transmitted? So the two major forms of transmission are droplet and contact. Droplet means that it is a respiratory droplet with a particle of about 5 to 10 microns or more in diameter. It can be generated with anything, with an infected person. Coughing or sneezing can really project the droplets, but also just someone who's talking as well, or just normal breathing can also spread droplets. For contact, this is from direct contact with infected people or with the surface that has been infected by someone with the coronavirus. And so think about this as well in the hospital on your stethoscopes or on thermometers. The droplets from someone's respiratory tract can remain viable for some time on a hard surface. Airborne transmission is a topic that has continued to come up. Airborne means a smaller droplet nuclei that can be aerosolized and remain in the air. It's under 5 microns in diameter. This is thought to mainly be generated during aerosol generating procedures. And what are those? Those would include intubation, non-invasive ventilation like BiPAP or CPAP, tracheostomy placement, CPR, also the ventilation that occurs manually before intubation, bronchoscopy, and then sputum induction using nebulized hypertonic saline. There's also been some studies to show COVID RNA in air samples without aerosolizing generating procedures. However, in those studies, the COVID-19 RNA was very low, and it's hard to know if those are viable virus able to replicate. The clinical presentation of COVID, which we're all becoming unfortunately quite aware of. The incubation period is 2 to 14 days, on average about 5 days. The most common symptoms are fever, cough, fatigue, anorexia, shortness of breath, and myalgias. Other less common but reported symptoms are a sore throat, nasal congestion, headache, diarrhea, nausea, and vomiting, and many people do report a loss of smell and a loss of taste. Risk factors for severe disease. So this includes older age of over 60 years old, and the more years past age 60, the higher risk for severe disease. Another large factor for severe disease that we've seen is obesity, with a BMI of greater than 30 to 35. Smoking and diabetes are also major risk factors, and we've also seen higher risk for severe disease with hypertension, cardiac disease, any chronic lung diseases, cerebrovascular disease, kidney disease, and then immunosuppression and cancer also place someone at risk for severe disease. Radiologic findings in COVID-19, and so you can see in both the chest x-ray and the CT scan here that most people will show bilateral imaging, bilateral disease, as opposed to unilateral disease. And you'll usually see patchy infiltrates and ground glass opacities, more so in the periphery than central. So to touch on treatment, which unfortunately, as we all know, there's limited options, but the two main drivers to think about for options of treatment are early on with viral replication and later in the stage where you have this exaggerated inflammatory response to the virus. And the WHO had the Solidarity trial, which recently had some results put out. They looked at remdesivir, hydroxychloroquine, lopinavir, and interferon beta. So in this trial, the COVID-19 inpatients were randomized between the study drugs that were locally available at the center. This included 405 hospitals in 30 countries, and 11,000 adults were randomized. Unfortunately, in the results of this trial, it does not show any of these 4 drugs having a reduction in mortality, both in unventilated or ventilated patients, and it did not show a decrease in the duration of hospitalization. So what can we use right now for treatment in the hospitalized patients? The biggest benefit that we've seen for medications are with steroids. And the studies were done initially with dexamethasone, 6 milligrams daily. This is a corticosteroid, and it was found to improve survival in hospitalized patients in the recovery trial. This was a large trial that was done in the UK throughout multiple hospitals. We also found at a hospital here at Henry Ford, a study here at Henry Ford Hospital, early on in our disease using methylprednisolone, we found a decrease in escalation of care. So we found less people requiring invasive ventilation. We found a decrease in hospital stay and overall improved survival with the use of early steroids. And when should steroids be started? So this should be initiated at any sign of oxygen requirement. If someone's not yet requiring oxygen, there has not been found to be benefit. But once you find someone is requiring any oxygen, which should be started at an O2 level of 94% or lower, then this would be when to start steroids. Alternatives to dexamethasone, if that's not available, are prednisone, methylprednisolone, and hydrocortisone. And other important non-pharmacologic interventions would be oxygen, supplemental oxygen, keeping a saturation greater than 94%, and then proning of patients. And so keeping people in a prone position has really proven to delay and hopefully prevent requiring invasive ventilation. So self-proning of patients who feel short of breath or require oxygen is beneficial. And then once people are intubated, proning is still beneficial. So in summary of treatment options, they are limited. There is no 100% effective treatment for the cure of COVID-19. There's only tools in the box to prevent severe outcomes. So that leads us to prevention, which is key in the role of COVID-19. So moving on to antimicrobial resistance in the setting of COVID-19. So what are the issues? Issue 1, many people with mild COVID disease are getting antibiotics unnecessarily. There was a review of studies published in hospitalized patients that identified 72% of patients receiving antibiotics and only 8% of them actually having a superimposed infection. And that was through this study here by Rawson et al. They looked at 1,000 abstracts and 18 full texts on COVID virus infection and antibiotics. And again, only 8% of patients throughout this amount had an infection, where 72% were getting antibiotics. So that leaves a large gap of unnecessary antibiotic use. This other study from Townsend et al. In September of 2020 also again looked prospectively at inpatients with COVID-19. They looked at 117 patients, and respiratory pathogens were identified in only 7 or 6% of these patients. However, 72% of these patients again were prescribed antimicrobials for a lower respiratory tract infection. So as we can see, again, a very large gap of unnecessary antibiotic use. This study just looked at how many patients throughout this study had confirmation of a bacterial infection. And early in the disease, only 3.2% of these 800 patients were found to have a bacterial infection. And later in the disease, still only 6.1. So there were some more later in the disease. However, still a very low number. So only 6.1% of these 830 patients in the later disease had a bacterial isolate identified. So issue number 2, COVID-19 leads to hospital admissions. So this leads us to an increased risk for healthcare associated infections, which in turn will lead to the transmission of multi-drug resistant organisms. And then as we talked in our talk earlier, that this can lead to increase in antimicrobial use, and then the cycle of multi-drug resistant organisms can continue. Issue 3 is that health services become disrupted during the pandemic. So this can cause interruptions to treatment for disease programs such as HIV and tuberculosis. Treatment interruptions for HIV and tuberculosis can lead to drug resistance in these realms. Also, vaccine interruptions can similarly lead to increased risk for infection and then overuse of antimicrobials. So what can we do? So importantly, we can increase the training of healthcare workers to differentiate signs of COVID-19 from other disease processes. This includes remembering that most people with COVID are not co-infected with a bacterial process and don't require antibiotics. And continue to use common stewardship practices. So as we talked last week, and as you can find in the WHO toolkit for antimicrobial stewardship, important things include de-escalation, avoiding unnecessary antimicrobial use, and optimizing appropriate use. And what does WHO say on the guidance of antimicrobials? So they recommend in both mild and moderate COVID-19 infection, they recommend against the use of antimicrobials unless there is a highly suspicious or confirmed bacterial infection. In severe COVID-19 infection, they do recommend empiric use of antimicrobials based on local pathogens and clinical judgment to be started. And this would be on the same lines of sepsis, trying to start as soon as possible and then obtaining cultures first. So moving on to infection prevention and control. What is the importance of infection prevention and control, and what is it? So it is a scientific approach. It uses practical solutions to prevent harm caused by infections to patients and healthcare workers. It's grounded in principles of infectious disease, epidemiology, social science, and the strengthening of healthcare systems. And it's rooted in the patient safety and health service quality. Why is infection prevention and control important? Without good infection prevention control measures, you can lead to transmission of diseases, including COVID, to patients, staff, visitors, as well as in the community. So whatever someone picks up in the hospital can be taken home and spread amongst the community, leading to worse outbreak. So who is at risk of the COVID-19 infection? Well, everyone is. The benefits of infection prevention and control, again, you want to protect yourself, protect your patients, and protect the family and community. IPC measures that can be taken. So things we can do both inside and outside of the healthcare facility. So wearing a mask is one of the most beneficial things that have been found in the outbreak of COVID-19. Generally, a droplet or surgical mask is okay. An N95 or respirator has been recommended for aerosol generating procedures in the hospital. Hand washing, again, always the number one thing we can do in infection prevention and control, important both in and out of the hospital. Social distancing and avoiding large groups are also important, as most of the virus is transmitted from respiratory droplets. Staying further apart has been found to be beneficial. And which mask to wear? So often we'll get the question of which masks are important and which ones are better. And so it has been mostly recommended for healthcare workers or anyone at high risk for severe disease to use a surgical medical grade mask. Droplet, again, is okay for anything except for aerosol generating procedures. And then cloth masks have become very popular and common, but we recommend those to be for people in the community who are at lower risk for severe infection. It's always important to remember how to wear a mask and to remind others how to wear a mask if you see them wearing one inappropriately. So hand hygiene is always important before and after putting on and off the mask. You want to make sure it's covering both the nose and the mouth. And when you're removing or putting on the mask, you want to put it on holding the straps and not grabbing the front of the mask. And you want to avoid touching it while you are wearing it. And if your mask becomes dirty or damp, you want to exchange it for a clean one. So physical distancing, again, very important. You want to maintain distance from others, both inside and outside of the hospital. You want to restrict the visitor numbers in the healthcare facility and reduce visitors as well. You want to enforce the 1 meter distance between people. And if this cannot be attained, try to cancel group activities if distancing isn't possible. Plan ahead what activities are going to be performed at the bedside to avoid multiple entries and exits when seeing patients. Considering bundling activities, instead of going in and out of the patient area who has COVID-19, try to only go to their bedside as needed and do more things at once rather than back and forth. Also, staggering meals is important. A lot of transmission we've seen between healthcare workers has been while eating. People kind of let their guard down and they take off their masks and eating in close quarters. And so this is an area of high transmission. And so try to enforce eating at different times or eating further apart or in different areas. Important IPC inside of the hospital. So it's important to triage patients. You want to recognize COVID early and also for better source control. You want to isolate or cohort COVID patients as possible, using contact and droplet precautions of these patients. So droplet masks, again, the surgical mask, that should be worn not only while you're seeing the COVID patients, but throughout the shift and throughout the hospital when you're around other people. And an N95 or respirator for aerosol generating procedures is important. For the contact precautions, you want to use gloves, eye protection, and gowns as possible when you're evaluating COVID patients to prevent spread to others and yourself. And while someone is in the hospital, you always want to evaluate the need for medical devices, as this can increase the chance of healthcare infections, again leading to increased antibiotic use. So the lab is very important in the role of COVID-19. They can help identification of COVID, but also other infections. So improving the lab capacity for identification of COVID is important to reduce the urge to use antibiotics. Once COVID is isolated and you know what that is, often we can stop other antibiotics as, like we talked about before, co-infection is very low. And also being able to identify and isolate fungal and bacterial infections is important to treat when it is there and as needed. IPC is always important to consider environmental cleaning. So cleaning the environment around you and in the hospital is important to prevent the transmission of COVID and other infections to patients. You want to have good ventilation for COVID. If the ventilation is not possible with the system, opening the windows is important as well. You want to clean high-touch areas and also disinfect medical equipment appropriately. You want to make sure there's appropriate linen management and waste disposal. And then consider the products being used for cleaning. Are they effective? And do they have a low selection pressure for antibiotic resistance? And we saw this in the previous lecture, but just as a reminder to consider high-touch surfaces with cleaning. And so think about bed rails, remote controls, door handles, monitors, and pumps. So prevention is key. There is limited treatment options for COVID-19, as we previously discussed, and antimicrobial resistance was already on the rise pre-COVID pandemic. And if we are careless with the antibiotics during the pandemic, they will continue to rise. And infection prevention and control plays a huge role. So what are the next steps to take? You want to review your own use of antimicrobials in your COVID-19 patients. Take steps to decrease unneeded use, and also teach and inform others around you. And if not already in place, you want to develop a team to prepare protocols for the COVID-19 infection and control measures within the facility. It's good to have a focal point or a team for the infection prevention and control to help stay educated on the new processes that keep coming out for COVID-19 and help to enforce policies. Thank you for your time, and we can move on to questions and discussion.
Hello,
Hello.
any questions?
I think Dr. Joshi is asking some question. That's
Hello.
it. Do you have any question? Yeah, we can hear you, Dr. Joshi.
I think thank you, Gina, for the nice talk. It's like you have mentioned about antibiotic use here in Nepal. What though our hospital is not a COVID hospital, but others are there. So one of the protocol here they have mentioned is like in mild cases they don't give any antibiotic, but when a patient becomes febrile, 100, 2 fever, and when oxygen goes down, the first thing is what we have started here is patient can have they have pulse oximeter at their home, so they change their oxygen saturations so that then they get admitted also, and we get oxygen, but usually we start with oral antibiotic. Most of the patients just azithromycin, though it's not indicated as I know because of the less than 5 or 6% have bacterial growth. But this is a thing we are doing for 4 or 5 days of oral antibiotics, the azithromycin, but we don't give any other IV antibiotics because the reports of culture reports will come late, at least couple of days. That is a more normal thing. But we are using dexamethasone in most of the patient and result is good. And dexamethasone we have been using for last 30 years. Like I graduated MBBS, medical college in 84, 83. So in our time also we use dexamethasone most of the patient in COPD. Okay, so we don't have that time hydrocortisone. So we are so used to using dexamethasone in those type of patients, at least 4 to 8 milligrams 3 times a day, and very cheap medicines. So this is we are very happy that it is one of the main medicine for one of the treatment for COVID. And remdesivir is very expensive for us, so it's available now. It costs about every day. It costs about 5 to 6 thousand, about $50, and the result is that not good. But whenever patient becomes severely ill, then we don't have choice. We have to give them this. That is a normal thing. What we do in the farm. Yes, Gina?
So are you completing a full course of antibiotics then for all of these patients that are concerning for COVID?
Yeah. In mild cases, we don't give any antibiotics, okay? But when patients have fever, this is a normal, most of the COVID hospitals here. At least we give azithromycin about 3 days. Okay, that's a rule. Though,
Mm-hmm.
we have give hydroxychloroquine also before. Even now, even in India, they are giving hydroxychloroquine, though WHO have mentioned it's not good. But like in India, every third or fourth patient of fever is malaria. Okay?
Mm-hmm.
So we are used to giving anti-malaria, hydroxychloroquine, chloroquine, so much because it's so cheap. It costs about 20 cents, okay, in one course.
Yeah.
So that have been using so rampantly. Even now, any fever, if you have to get for malaria also, you have to get a blood test, blood samples. Out of 10 to 20 samples, you may get in one sample, positive, or you have to go for bone marrow, liver biopsy. So that's not done. So medicine is so cheap, and this is for Dr. Marcos also. What I'm to like, impress is we have been using chloroquine and hydroxychloroquine for fever cases and in so many of rheumatoid arthritis, all those cases. We have seen very, very few patients with cardiac abnormalities, okay, arrhythmias. In my whole life, I have seen just 4 or 5 patients dying of taking chloroquine, hydroxychloroquine. So that is in my last 30 years. And when I was in India, I did my, bachelorship and PG in India, in Calcutta and New Delhi. So we give each and every patient, any patient with a fever, they give hydroxychloroquine. So patient died when they have G6PD deficiency, okay? Then there's a drug reaction, very severe. G6PD deficiency, There's a genetic deficiency you see in some few villages. Otherwise, very safe medicine. That's my personal opinion. Though in Europe and United States, there's lots of cardiac arrhythmias and those things. But in Nepal, in our experience, we have seen very few cases. These are my personal opinion. What of Dr. Marcus? Can you just, maybe because this is a very cheap medicine, so the pharmaceutical company, they don't want to, say that, oh, this is big thing, or the dexamethasone also. And now we know that remdesivir is just such a hue and cry, oh, this is a wonderful drug. Now we know that it's not working. So what's your comment about?
Yeah, no, sure. So no, thank you for your comments, and Gina, thank you for your presentation, and welcome to everybody that is participating. The main thing with the hospitalized patient with COVID is I think is the early steroids, and the thing with the steroids is that it can't be too early or too late. So if there are some data to show that in an outpatient setting, giving steroids too early is not good. But when somebody is hospitalized, I think the steroids have very clearly shown and has been supported by a variety of studies that it's beneficial. And remdesivir, which gets a lot of attention, is not available in many countries. It's expensive, and it really is unclear, even what mortality benefit has been shown. WHO has even recommended against it. So the thing with COVID is mostly supportive therapy, like Gina mentioned, oxygenation and ventilation if they get sick, and then managing bacterial infection, is needed and is supported by the literature. The cardiac stuff, things are the COVID itself can cause cardiac abnormalities. So when somebody has a cardiac abnormality, it may be because of myocarditis, because of COVID itself. With hydroxychloroquine, chloroquine, these are drugs that have been available for 65 years. They're safe, and there are data to show worldwide that if given early, there's a benefit to doing it. It's safe. There's the cardiac toxicity that's been shown in some studies were small, poorly designed studies, and they don't take into account the myocarditis that can happen from COVID itself. So the randomized trials that got a lot of attention for COVID, they're with hydroxychloroquine, there are problems with them. They're either not powered to show a difference. When one exists, there are issues with blinding, issues with analysis plan. But the main thing with them is they're not given early. Some of these studies, somebody could be in a hospital for 10 days and then get hydroxychloroquine, and then it's not going to have a benefit because by then, there's already the inflammatory response. So it has to be given early if it's going to be beneficial. So I'm still supportive of its use, but in the United States and Europe, it's so political that it can't be done. But to me, it's just crazy. So it is, but I support its use.
Yeah, thank you. Like when I talk to my Indian friends in India, they say, Dr. Joshi, don't think about United States and Europe. We have been using hydroxychloroquine and chloroquine last 30, 40 years before we were born. And such a cheap medicines, so why not? And dexamethasone also the last 30, 40 years available in India and Nepal is so cheap. It's less than 20 cents, dexamethasone so cheap.
That's the thing.
Remdesivir, initially it cost about 50,000 rupees. That comes around $500 in black market. Now came down to it's about $60 or $70. It's too expensive for us, and we know that none of them work.
Right.
So we have done here plasmapheresis also to some patients. Plasma transfusion also, that doesn't help.
No.
And if patient is sick, I think we don't have any medicine. It's more supportive, right?
So the convalescent plasma, the data on that was very, there was a little bit of retrospective data initially that that might have shown a benefit, but later studies don't show a benefit. So there's limited benefit, if any, to plasma. And then the monoclonal antibodies, which are also very expensive, has shown no benefit in hospitalized patient. Maybe some benefit outpatient, but it is, but they're also require IV infusion. They're not available in most countries. They're not even available to us here in the United States. So we've already spent millions of dollars on remdesivir, and And again, hydroxychloroquine is is an inexpensive agent. There are data from all over the world of benefit. So I support what you're doing.
It
Yeah.
costs about 10 rupees. That is about 10 cents one tablet.
Yeah, there you go. That's the thing.
But we use, like most of the center here, whenever the patient remains prolonged period in the hospital, then they have secondary infections, that's
Right.
quite normal. And if they are on ventilator, then there's definitely, so then they have to use higher antibiotics. That's the rule.
Yeah. The other one that's important, is the management, of course, the management of complication, bacterial infection, but the other one that is increasingly recognized, and I just had somebody just the other day that had our pulmonary embolus and microthrombi. So to watch out for that is also important, which tends to be a little bit of a later complication. So I see a question about the how does hydroxychloroquine help? It's because of the anti-inflammatory property of it, and so it has to be given before the inflammatory storm because it has anti-inflammatory properties. So, and it works differently from steroids. So it is complementary or additive to the steroid.
Here in Nepal, just so you know, I just like to mention, and India, and any foreign people traveling to India and in Nepal, southern part of India, where there's malaria. So when the foreigners come, they take either chloroquine or hydroxychloroquine for preventive purpose also, and they till they stay in Kathmandu, Dhoj area. So this is that common. So
Right.
as you said, it's more political and financial thing.
Dr. Joshi, do you feel like with the hydroxychloroquine use in Nepal, does it seem to be a benefit from everyone there?
I think at least there is no harm. If you ask me,
Mhm.
as a preventive also, initially we took for a couple of months, myself and my family and other people also, okay? But I'm not saying that help us, that we don't have, but still, because it's so cheap and rheumatoid arthritis, every people is using this, okay? And any fever, pyrexia for a couple of days, more than that, they're using chloroquine for, 3 days for malaria. So I think there's not much of harm. But India, when I ask my friends, they have a protocol. They still use hydroxychloroquine, dexamethasone, and they use antibiotic like azithromycin for 3 to 5 days like that. Now that's a normal. That's what, because all of them are cheaper. Dexamethasone, it costs less than 10 cents. Hydroxychloroquine 10 cents, and azithromycin about 20, 30 rupees, 20, 30 cents. So at least that is.
Mhm.
That can they manage. Otherwise, it's quite expensive, But when we know now that remdesivir doesn't work and plasma, transfusion also doesn't work. Then so lots of millions, billions of rupees have gone down on the drain, right?
Right.
So when you know that that's not working, what is your comment about that?
Yeah, no, I think the main thing is the
Hello?
supportive therapy, oxygenation, the early steroids. I think managing complications. Those are and I do think that the hydroxychloroquine or chloroquine are beneficial, and it's a safe agent. So it would be but I think it would be important to describe the experience in Nepal because there are probably some people doing it and others not doing it. It would be good to describe the experience in Nepal.
Yes. Okay, I'll talk about that.
Yeah, I will say that here in the United States, the FDA had approved remdesivir, but that was just before the WHO Solidarity trial came out saying that there's no benefit and recommending against the use of remdesivir. And I'm honestly not sure. We've been using it in our hospital, but I feel more like the steroids are what make the biggest impact. And I'm not really sure that the remdesivir is making impact or not. And it's, like everyone said, very, very expensive too.
Very expensive. We are using, and now it's we get it from India. Now it's slightly cheaper. Otherwise, that was very expensive. But still, when patient become very sick, here doctor they don't have choice. They go for remdesivir. And just one comment, Dr. Margot. Here now the big market in pharmaceutical companies. Everybody is now having this Prevena 13. That's a vaccine for this pneumococcal pneumonia. And then everybody is taking vaccines for influenza now. It's very short. This Prevena 13, you have in United States both 13 and 23 polysaccharides, right? But here in Nepal, we have only 13. And this now it's everybody is taking this because they think that with this they might get some help. So anybody who can afford that costs about I think about $70. So using this vaccine for pneumococcal vaccine and influenza.
So, I think, influenza immunization is important because, want to get flu and COVID at the same time. Yeah. And pneumococcal immunization is also important if that can be done. It is, I think, so the problem with the 13 valent is that it's, there's some serogroups that it doesn't cover. The standard Pneumovax, covers more serogroups. So, but I think, either one that are available or both, if you can get them for immune compromised patient would be, is a good idea because it does prevent pneumococcal pneumonia. Hopefully, we'll get the COVID vaccine soon and it'll be available in Nepal for you also.
Dr. Lisa, any comment from your side?
Dr. Gina, there is just questions in chat box from the Deepak Yadav. Maybe you can see that. Dr. Gina?
Okay, so, yep. So he asked, can Sunrise full treatment protocol with drugs and dozens in COVID-19 symptomatic severe, very severe case? I'm not entirely sure what the question is asking. Maybe if they want to unmute and rephrase the question.
Till vaccine is available, no? Cancer full treatment protocol with drugs and dozens.
I will say that once the COVID-19 becomes very severe, there's really not much that we have to help with it. So the biggest point that we've made is prevention is most important. Of course, the vaccine will be beneficial, but until the vaccine is out, I would say people need to keep doing the prior recommendations of social distancing, wearing a mask, good hand hygiene, because prevention is really key. We really don't have a good therapy. Steroids seem to help, but they're not 100% effective in preventing a bad outcome. There's really no other treatment, and especially once someone is intubated, we have nothing helpful at that point. We just have supportive care, and we hope that people improve. But most of the effect is before someone becomes intubated. So there's really nothing there that's shown to be beneficial once someone's already hit that severe phase requiring intubation. I will also just plug that once the vaccine is out and available, I wouldn't stop doing all of these measures though, because none of the vaccines are shown to be 100% effective. And so I would not just walk around with the vaccine thinking that you're 100% immune. I think it will still be important to continue to social distance and wear a mask until the community levels especially are very low. But of course it will be quite helpful.
Excuse me. Actually, my query was like in Nepal, till now, actually mortality is still in stagnant. No, every day we lost around 20 to 30 people. So these are the like very severe cases of COVID-19. Okay, and due to a lack of facility of this, ICU and ventilator in our country. So is there some your treatment drugs which is like very helpful till this vaccine will come? My question was like this.
Okay, so for the severe patients, again, because even like something like remdesivir, for example, that's really only been shown, it's an antiviral medication. And so it's really, even if there is a benefit, it would still be early. Once someone is severe enough to require intubation or close to intubation, we are assuming they're no longer just in the viral replication stage, but more in a host inflammatory response. There has been some people that have used like interleukin inhibitors, like IL-6 inhibitors. I think the data is still mixed with those as well. Some people do feel like, especially in obese patients, maybe it can be helpful. But then there's also the risk that comes with them of possibly superimposed infection later. But so we've used that sparingly, but that's really maybe the only other tool in the box for someone who's already in a severe state. Again, the goal is always to try to catch people early, but we see it here as well where people are coming in and they step in the door and require intubation. So there's nothing we can do once they're already here. So IL-6 inhibitors are a possible choice when you don't have anything else, but those, we've also only really used them in people on already requiring intubation or on high flow nasal cannula. I'm not really sure if you don't have the access to a ventilator, it's possible. Dr. Zervos, do you have a thought on that for someone if there's not capacity for a ventilator? Anything else at that point?
Very nicely said. But actually, what I would like to share that in our experiences that very young people were died due to COVID-19, and they were found like sudden heart attack. Is it like
myocarditis? That's quite common.
Yeah, so
few cases, even hospital worker, they were like quite, I mean, well till evening, and midnight feel some problem and sudden death. So this is like happening. Yeah. So is there any preventive drug for the heart disease? Like I mean, COVID, not heart disease, but in COVID, like can we use aspirin simply or something?
Aspirin. We have been using aspirin in all the patient. Okay. Then we give enoxaparin also in, I mean, the prophylactic dose.
So
that's what we are doing.
The other thing to think about, we've seen some people that are, they look like they're doing okay, and then they go home and they just suddenly die. But what maybe cardiac, but what may also happen is that when people ambulate, then the pulse ox goes down. So the pulse ox is okay, when they're resting, but if you ambulate them, the pulse ox goes down, and it may be because of that they're that they suddenly die. Is that they ambulate and the pulse ox goes down. So it's something to watch out for. I actually think the aspirin not a bad idea, but it hasn't been well studied.
Mm-hmm.
Just small comment.
Oh, sorry.
Here we are giving most patients when they are aspirin, and they get the enoxaparin, okay, blood thinner also, at least once a day, not twice daily. And most of the patients, they get multivitamins and vitamin D, all those things. That may be placebo effect. We don't worry about that. It is not going to harm them. But one thing, when we want to put on ventilator, what we found, the mortality rate is very high. But when patient is on just high flow oxygen, mortality rate is less. So initially, everybody wants to put on the ventilator. Now we try for the high flow oxygen, 15, 20, 30, 40, 50 liters also. Then if not possible, then we'll go to ventilators. What's your comment, Dr. Gina?
Yep, so I will add on that. We definitely have found benefit on high flow if that's available over ventilation. We found doing the very high flow up to 60 liters can help prevent intubation, because once people are intubated, they seem to stay on the ventilator for a long time, which is bad for them for infection risk and other issues, but also takes up a ventilator and hospital bed and space. So high flow is definitely a great idea. And I will also say that anticoagulation is very important. We've seen strokes and heart and pulmonary, so we can see thrombosis anywhere. And so definitely anticoagulation is very important and can hopefully help some of those cardiac or pulmonary deaths in some of these young and, well, really everyone, but some of those young patients you're describing as well. So I think those are both really important things. And then also just proning. So never forget the benefit of proning, anyone requiring oxygen. So from the moment you put on oxygen or just feel short of breath, through high flow, through intubation. So proning as much as someone can is also helpful for the respiratory side. We have also used in proven myocarditis, or highly suspected, I should say, we have used IVIG in select cases for specifically in myocarditis for treatment of myocarditis as well. And I do see another question asking, what is the golden time for treatment with plasma and remdesivir? Plasma, I would say some people are still using and some aren't. There's not huge shown benefit, but again, probably not harmful. Same with remdesivir, but the best time for these would be early on. So the same time that you would start steroids would be the same time you want to start these other interventions like remdesivir if you are going to use it. Because remember that remdesivir especially is an antiviral, and we think the viral replication occurs early in the disease. So if someone's already in the severe late part of the disease, remdesivir probably is not going to have any benefit at that point because it's no longer in the function of the antiviral phase of the disease. So early on is best if you are going to use these alternative therapies. All good questions.
I think we have very interactive program today, right? Yeah.
Yes, and COVID unfortunately is still the hot topic.
In Nepal, I think even in the United States, everybody is expert now with COVID. You go to any housewife,
Yeah.
you go to any people, they know all the theories. This is good, this is bad,
Yep, that is true.
Very
Definitely here as well.
I think, Linda, there is no more questions. So can we move in next agenda?
Yeah. So we'll have our brief remarks with Dr. Joshi and then Dr. Zervos.
Yeah.
I think we have already have all
Mark,
the
go ahead.
So you see, we have to thank Dr. Gina, Maki, for this very nice talk about COVID, about COVID and about the role of antibiotics. No role of antibiotics actually, and then IPC also. And I have to thank Dr. Marcos also that we have lots of new, this information about COVID and what's happening in the United States also. So I think we have lots of discussion about that also. More than 20 minutes. We have the interactions quite good. Marcos now.
Yeah, so I want to thank everybody for your attention, and Gina for giving the talk, Dr. Joshi for working with us to organize this, along with Deepak and his group. It is looking forward to the time when we can come to visit Nepal again. It was just about maybe about a year ago that I was there. And just before COVID started, so now of course the travel is limited, but we stay in contact and continue to work together now virtually, and we are all together in trying to deal with these important issues. So thank you everybody for your time and your attention.
Thank you and namaste. Next year, 2020, we'll be meeting again. Don't worry.
Yes.
That's Linda Linda, for your closing.
So I will just quickly again thank everyone for joining us today. thank Dr. Maki for her presentation, and Dr. Zervos and Dr. Joshi for their comments and responses to questions. And I will echo that, we do hope to see everyone face to face sometime in the future.